This afternoon, I'm very pleased to introduce somebody whose work you may have seen a little bit of already, because there is a poster in the poster hall which shares some of the information that will be discussed this afternoon. However, there's nothing like in person. And so at this ThinkSono sponsored symposium, I'm very pleased to introduce Kerstin Nothnagel, who is responsible for introducing new doctors to ECG interpretations, ultrasound of the vascular system and ultrasound of the abdomen, providing overall perception of non-invasive ventilation, and she works in the Bristol area. And today, Kerstin will be presenting on the ThinkSono AI device. As a background, during her MSc, she worked to highlight the importance of implementing AI technology in vascular diagnostics to enable the healthcare system to cope with an ever-increasing volume of patients. Her most recent research project investigated the sensitivity of artificial intelligence as a diagnostic tool for DVTs and compared to the gold standard ultrasound performed by a specialist sonographer based in a hospital. And so this afternoon, Kerstin is going to present about this. So I will pass you over now. Thank you.
Thank you so much, Jo. That was a lovely introduction. I am very pleased. So ladies and gentlemen, my name is Kerstin Nothnagel. It's a German name. That's the reason a bit different and pronounced already. I'm a PGR. I'm a postgraduate researcher from the University of Bristol, but I also work as a physician associate at an emergency department. Today, I will present my pilot study I performed at a German hospital over a period of 3 months. AI-guided point-of-care ultrasound to diagnose deep vein thrombosis. Before I start my presentation, ladies and gentlemen, I would like to take you on a little journey. Next slide, please. Hospital overcrowding, form torture, increases risk of death. That's a newspaper article from March 2022, not long ago, but nevertheless, we see this quite often in the news. Overcrowded accident and emergency departments. Healthcare providers can't cope with their workload. You can see on the image, patients queuing up in the hallway. There's not even space anymore in the rooms. We are faced by an aging society. We have less and less people in the workforce. It is now time to think about solutions. And today I will introduce my project, and maybe that will be the first step in the right direction. Well, I will leave this image with you, and we can start now with the presentation. Next slide, please. Well, Jo already mentioned my poster of the pilot study is in the poster room, so you can look at this in detail later on if you're interested. And the poster is connected with a little slideshow where I talk about my project in more detail. But this presentation will give you a nice overview. Next slide, please. So the background for Thrombosis UK. Deep thrombosis is a blood clot which mostly occurs in the deep veins of the leg. Interesting is that 7.7 million people require DVT investigations per year. And in general, DVT diagnostic is performed by specialists in hospitals. Unfortunately, the current diagnostic pathway is laborious and time-consuming. Patients with DVT symptomatic or who have pain, redness, or swelling of the leg will initially present at a GP. If the GP will do a good examination, takes the medical history, will calculate a well score. That's like a probability score. How high is the probability that this patient might have a DVT? And might also do like a rapid D-dimer test. That's like a blood test, which also can indicate if there's a clot or not. If the GP has a suspicion that this patient might have a DVT, he will send them mostly via an accident and emergency department to a vascular specialist. Despite that DVT is quite a common disease, you can see that the diagnostic pathway is not straightforward. Next slide, please. Artificial intelligence in vascular diagnostic. Well, we touched this already. The startup company ThinkSono developed an AI-guided AI software called AutoTVT. This new development can is an AI-guided ultrasound that potentially any healthcare professional can use to perform a DVT scan as a point-of-care ultrasound. For example, a nurse in a nursing home could perform a DVT diagnostic at a patient in the nursing home, or a district nurse could perform a scan for a patient in their home if they have swelling, redness of the leg. So this patient group wouldn't need to travel to a specialist, usually at hospitals, to get diagnostic done. So the AI, you can see on the right-hand side, it is actually in the size of a mobile phone. You can see the veins in a greenish hue and the arteries in red. The AI is used to guide the operator through the DVT scan of the leg. So it will tell the operator exactly where to put the ultrasound probe, go more left, go more right, now center the vein or the artery, and then compress. If the operator here on this image, what you can see here, compress, the vein would completely collapse if there's no thrombus in there. So you actually wouldn't see the vein anymore, you would only see the arteries. This model is, how I said, based on this, that a vein without a thrombus will totally collapse when compression is applied. Next slide, please. So how does it work? I started already up. So for example, a nurse at a nursing home could perform this AI-guided scan as a point-of-care ultrasound. After the scan, the operator would upload the scan on a cloud dashboard. And this would enable like an external specialist, for example, a radiographer at a hospital, to review the images. And you can see this cloud dashboard on the right-hand side of the screen. In front of it is the AI software, that's what the operator would see. And then behind it is the cloud dashboard, what the external reviewer would see. So these sine loops of the scan. The operator can then instantly write a diagnosis. Yes, I can see this vein is completely compressible, or yeah, there seems to be a clot. This vein is not compressible. This would enable local diagnostic and local treatment, as the external specialist will instantly write a diagnosis, and the operator at the patient's bedside can see the diagnosis and commence treatment. Nevertheless, the auto-DVT by itself will give a diagnosis. But in our time, the diagnosis, the final diagnosis always will come from the physician. So from a physician, for example, from an external radiologist. Next slide, please. So that's about my little pilot project. I recruited 91 patients at a Berlin hospital over a period of 3 months. 16 patients had to be excluded because they didn't fit the inclusion criteria. And the AI-guided scan performed by a non-specialist had then been compared to the gold standard scan performed by a specialist, here an angiologist, a consultant of the vascular diagnostic. The images were uploaded again on the cloud dashboard, and 5 external radiologists actually looked at the images and gave their input if there's a DVT or not. The sensitivity and the specificity were calculated for the AI software and for the reviewers, the external specialists, separately. All scans where the vein was completely compressible were put in a low risk group, and indicating that DVT potentially could exclude it without a specialist scan, as it's obvious that this vein is fully compressible. The other scans were put in a high-risk group, indicating, well, this vein wasn't fully compressible, or there is something not quite clear. This patient group needs to be seen by a specialist that would require a DVT scan. You can see on the right-hand side of the slide the flow chart of my pilot study. So 91 recruited patients, 16 were excluded. Then the images were downloaded on the cloud dashboard. So 75 patients, again, 7 had to be excluded because the image quality was not adequate for external review. And then 48 of these patients showed compressible veins and 10 incompressible, and 10 were others. Was not quite clear. Next slide, please. So the results. From this 75 patients, the AI software showed actually a whooping sensitivity of 100%, what is really good, and a specificity of 49%. I mentioned before, the reviewers looked on all the images, but had to exclude 7 more patients as the image quality was not sufficient enough. But the images they reviewed showed again 100% sensitivity and a specificity of 91%. So with 100%, DVT could be excluded, and the specificity was 91%, how I just said. So 27 patients were considered as high risk, and 48 patients were considered as low risk. All patients in the low risk group, where the veins were completely compressible, were put as negative for DVT, and indicating so that 64% of all scans could have been avoided as a DVT scan at a hospital or in secondary care. And using AI could so significantly reduce the amount of patients presenting at DVT clinics or secondary care with their symptomatic of DVT. Next slide, please. So conclusion, you can see on the right-hand side again, the ORTTVT, the different compression points, and the external radiographer writing no pathology found, or putting their comments about the diagnosis and what the operator of the ORTTVT or the ultrasound device at the patient side instantly can read. So the AI can aid non-specialists in acquiring valid ultrasound images of venous compressions, which are of adequate quality to remote diagnosis by experts. So like radiographers at the hospital can give their diagnosis, but the scan is actually performed as a point of care by non-specialists, for example, in patient's home. So this would allow a point of care DVT diagnosis without the need actually from the physician to be on site. AI-guided ultrasound might especially benefit patient groups such as elderly, housebound patients, patients in nursing homes, patients multimorbid in their home environment, which are now, with the old diagnostic or the current diagnostic pathway, need to be guided by transport to their GP, from transport to the accident emergency department, and from there to the vascular specialist. An enormous pressure on such patient groups. This patient groups highly affected by DVT. Next slide, please. Well, I'm coming back to my first slide. Hospital overcrowding, form of torture, and increases risk of death. Well, you just listened to my presentation introducing AI-guided ultrasound scans, which could enable non-specialists to perform point-of-care ultrasound in primary care, in the community, at patient's home. Could this be a solution to take the pressure of specialists in secondary care? I will leave this so you can think about this, and well, that might be a first point for change in the future. Next slide, please. So with my last slide, I will actually give a little outlook in the future. You can see again on the image, the ORTTVT, very sleek handheld ultrasound device here connected with Clarius L7. It's easy, portable, and easy to operate. So the AI-guided point-of-care ultrasound could enable DVT diagnostic in primary care, local diagnostic without specialist equipment, and without the need to book multiple appointments. And wider effects of this technology could include reduced accident and emergency department visits, so freeing up time of specialists and leading to improved patient outcomes, and an overall reduced financial burden for the NHS as late diagnostic often can lead to pulmonary embolism, to post-thrombotic syndromes, and this patient have chronic conditions then and would need ongoing care, having a great financial burden for our NHS. Last slide, please. Ladies and gentlemen, thank you so much for your attention, and I'm looking forward to your question.
Thank you very much, Kerstin. That was very interesting. I know we have some questions that have come in. And so in setting this up in a medical centre, have you set it up in any of the UK centres at the moment?
Well, the project I just talked about was actually a small pilot study, and actually we had only a small frame of 3 months to perform it. I performed it at a hospital in Germany, in Berlin. I'm German, so it was easier for me because at this point of time, I felt it would be easier, and I had connections to this hospital already to perform a study there. Nevertheless, I mentioned on my first slide, I'm working for the University of Bristol. And at the moment, we are starting up a new project to introduce this device in primary care. Until now, the ODTVT has been only tested in secondary care. In secondary care, you always have lots of people around who can help you with scans, or you have specialists there. But actually, this device is really created for primary care settings to enable actually point of care diagnostic for especially patients who are unable to walk, who are multimorbid, who actually don't want to go from their GP to A&E, from there to the vascular specialist. But this project is only starting now, so we are in the planning time. So it will take a couple of years more to have the final results.
Okay, thank you. That's interesting there. And in your initial setup in Berlin, did it take very much time to train people to use these and to implement the software that you have to have for this?
Actually, it is quite straightforward. The training involves the training for the ODTVT more or less takes like 2 or 3 hours. So for example, when a HCA, what we're doing at the moment, a healthcare assistant would perform a scan, you will assume that they actually don't have any background knowledge of ultrasound prior. They could watch like a video clip of 2 hours and have like a short half-an-hour session, how to hold the handheld ultrasound probe. And then they're actually able to perform the scan. The AI is very good to tell the operator of the device, the HCA, exactly, no, that's not quite correct. Go a little bit more left, go a little bit more right. Well, that's the right anatomical position. So it's actually lots of guidance, and yeah, and this enables then non-specialists to perform the scan. Okay,
so it's the basic training, but then it is also sensitive to guide the user in using it.
Exactly. Well, when I performed the study in start of 2022, well, I actually want to say since then, it's an ongoing process. So the ODTVT gets improved with more and more data. So by now, the systems are actually already much better than in the time when I performed the pilot study. So I think 2 to 3 hours training to perform AI-guided scan is not much of a training what is needed, but by now it's even better. So it's adapting to the operators, and the images are much improved than before they acquired.
I mean, it's very exciting to see how this sort of device and software could fit into the DVT pathway and therefore benefit everybody, benefit the NHS and that point of care for the individual, but also for the individual avoiding both delay, but also that travel and wait time. Yeah, exactly. But once they've taken, so you mentioned it, and I think this is probably part of your trial, but once it was taken, while the scanner can tell you things, it then goes off to a radiographer to review it and to feed back. Is there very much delay in that time?
It is actually not. It is quite instant. So we had a team of external radiographers. So as soon as the scan was finished, you upload it. That takes only like a few seconds, literally. And the external specialist can instantly see the images on the cloud dashboard, given that he has the cloud dashboard up and running. But in a hospital, that's quite, you have several screens and you have it always open probably. So that was the future thinking. And it will take the radiographer quite a short time, a few minutes, probably like maybe 5 minutes, to go through the images and design loops, seeing how the vein is compressible or not, and then write a little diagnosis. I even would think that that is more sufficient looking on images and can go back, scroll back and forward, and to look again on the vein to make sure there was seriously nothing in there. Then sometimes on the spot, when you're distracted from lots of people coming in and asking you questions, and now you're sitting in a room and can really focus on your one patient on one scan to give the diagnosis.
It's really interesting. Obviously in tests and trial settings, it's a little different, but going forwards, would you see then the need to perform a subsequent confirmatory ultrasound scan if the AI device was showing that it was positive?
Well, that's what I did study, or what I just introduced. So we said, well, we are all aware that when you have a DVT symptomatic patient, literally 10 to 15% of the DVT symptomatic patients are only maybe 15 or 10% positive of, sorry, I don't know if that's right. If you have 100 patients with DVT symptomatic, only 10 to 15% of these patients are actually having a DVT. So what we said in the study is like this 85% who come with the symptomatic, but we can exclude externally, like in primary care, for example, that they're having a DVT. This patient group does not need to present at an accident emergency department for further diagnostic. We could see the vein is completely compressible, so there's no further scan required. All other, like the 15%, so in a high risk group, will need to present for a scan with a specialist.
Okay, but it certainly would be working towards reducing such a high number of presentations.
Definitely, yeah.
And then over the years, as more data comes in, that may be reviewed again. But yeah, thank you. And it will be very interesting to see, as you mentioned, in the project that is just beginning, seeing it in a real life setting around in the community, where I'm sure there is both the training to provide from people who perhaps have individuals in healthcare who hadn't been involved in this sort of work before, and so confidence building, but also in the benefit that it might bring to patient at that point of care.
Yeah.
If people want to find out more, so they can go to your poster, and there's lots of information about the trial that you did. And I think also ThinkSono have an exhibition in the exhibition hall. So if anybody wanted to talk to the ThinkSono team or find out more about this device, and also maybe how they could become involved in ongoing trials and research or studies, would that be the way for them to find out more?
Exactly. So you have, you mentioned this already quite nicely. So you can one time see more details about the study at the poster exhibition, but you also can go directly to the information point, ThinkSono. If you click on the website from ThinkSono with open, you will have different animations, how the device is working, how it is currently implemented, what kind of studies have been done, and obviously the contact details of ThinkSono. And we're always very happy to give more information and to hear of your feedback.
And lastly, I would think that as your next research work begins, you'll gradually be advertising for recruitment once the initial stages have been set up. Is that correct? And so people can hopefully hear from you or make contact with you if they were interested.
Yeah, I would be delighted. Yeah, please. I'm very much looking forward to have more questions, and it's also for me to expand to approach people correctly, to tell them about what we're doing or what the aims are to improve this diagnostic pathway, put it in, make it more accessible for patient groups like elderly, housebounds, or what does the community think, how it should be implemented in future.
Okay, thank you very much. Very exciting opportunities in the future. Thank you so much. I hope everybody has found this very interesting. The recording will also be up on the platform very shortly, so you can go back and do have a look at Kerstin's poster, which was reviewed and accepted into the poster hall, which is brilliant. And also, if you would like to know more about ThinkSono and the AI device, please do go to the exhibition hall. But for now, thank you very much.